Would like to mention that we are recording that that is part of the session, so we can share it later. But please know that anything listed in the chat will be seen in the recording. My name is Raquel Romero. I hope you and your family are doing well. I'm a physician by training, and I'm going to be the facilitator for the ECHO session today. We have a lot of information to cover, but before we begin, I would like to ask our UT equality person, Carly, to provide some directions for us. Carly, on your time.
Hi, please stay muted unless you're speaking. You can mute or unmute yourself by using the *6 on your phone if called in, or the microphone icon on the bottom left of your screen if you joined on the computer. You can also communicate with the chat feature. If you're having issues with your connection, you can privately chat UT Echo IT. Thank you.
Thank you very much, Karen. As I was mentioned, just remember that if you have some issues with the connection, you can add your comments in the chat box, or you can send a private message. Also, I would like to invite you and encourage you to add your comments, your questions, and suggestions using the chat box. We will try to follow up them through the session today. And also, you can reach out to us after this session by email. We promote interaction in our sessions, and I would like to invite you, and if you're able and comfortable, please join us by video, particularly in the discussion part of the session. And please remember that no personal health information is allowed within discussing cases and scenarios. These sessions are open to everyone. When you register for one session, you are invited for the rest of the sessions. I would like to go ahead with the introductions, and we have a large group, so I would like to invite you. Please add your name, your title, your contact information in the chat box. This is for our attendance record. Health Confianza is a countywide collaboration to improve access and the uses of the COVID-19 health information and service in Bejar County. With that, and I would like to start doing the introduction for our COVID-19 health literacy ECHO team, and I would like to start with Dr. Bergen.
Hello, everyone. Welcome. We're so delighted to have you. This is going to be a great session. I am a professor of medicine and infectious diseases at UT Health and a very proud member of the Health Confianza team, and I will be moderating along with my colleague, Dr. Raquel Romero, today. Welcome.
Thank you very much, Dr. Bergen, leader specialist. We have Dr. Garcini for the doctor's presenter today.
Thank you, Raquel. Hi, I am a licensed clinical psychologist, and I am an assistant professor at the Department of Psychological Sciences at Rice University and an adjunct professor at the Center for Research to Advance Community Health at UT Health San Antonio.
Thank you very much, Dr. Garcini. We have a panelist, Dr. Kemp.
Hello, everyone. I'm Kenneth Kemp. I'm a pulmonologist, retired Army colonel, and still work with Brooke Army Medical Center. And I'm the pastor of the Antioch Missionary Baptist Church.
Thank you. Thank you very much. We have Joaquin Abrego as a panelist and case presenter today.
Hello, everybody. I'm Joaquin Muerte Abrego. I am the Community Outreach Coordinator with Health Confianza. I am also a community activist, social justice activist, and a musician.
Thank you very much. We have Dr. Katie Case as a hub.
Hi, my name is Katie Case, and I am an assistant professor at the Center for Research to Advance Community Health and a member of the Health Confianza.
Thank you very much. And I hope we have another panelist, Tia Gibson. I'm not sure if he's showing us already. Maybe we can introduce her later. And thank you so much for our ECHO team for making those sessions possible. I would like to mention that thank you for joining us, and your feedback is so important. So please complete the evaluation that you're going to receive at the end of the session. And we're always looking to invite clinics to participate in those ECHO sessions. If you know a clinic or provider organization that would like to join us, please let us know. We want to invite them and to be part of these sessions. ECHO stands for Extension for Community Healthcare Outcomes. So this model is a learning opportunity and a mentorship. And the goal is to bring the knowledge when it's needed, where it's needed. Part of the core elements are the case discussion and the didactic presentation. I would like to then continue with the didactic presenting with Dr. Garcini on your time. Thank you so much, Dr. Garcini.
Thank you. Well, thank you for the opportunity to share with you some of the insights that I and my team have learned from the community and listening to them in terms of what can we do to improve communication so that people feel that they've been understood, so that people can trust us, so that we can work together as partners to get out of the current health crisis that we've been having for the past 3 years. Next slide, please. So these are just some of disclosures about my work and my funding. Next slide. And the objectives for today is to talk about very simple, practical things that we can do to improve communicating with patients, particularly those from historically marginalized backgrounds. These are probably things that you do in your everyday life, but sometimes it is important to increase our level of awareness at the huge role that these practical skills can have in communicating with our patients. And then we're going to explore some strategies using some of the cases that we'll be talking about today in terms of improving communication. Next slide. So we all know it's not surprising what we've been through over the past 3 years. However, I want to invite everybody to reflect that it's not only a health crisis, but unfortunately for several historically marginalized communities, this has also been a socio-political crisis that has increased distrust among all of these communities. It has led to a lot of confusion, so people don't know what to believe, who to go to. So it is important that we acknowledge those contexts when we try to address health issues in these communities. Next slide, please. So I think if you can pass on, because we have, keep going, and the things will be appearing. So we know that we have a widening health disparities and health inequities, but we know that these cracks are not new. We know that these cracks existed long before the pandemic. It have resurfaced, but the gap is getting wider. And we know that if we don't address this now, it's really difficult to close any of those gaps. So you probably have heard a lot of the term health equity thrown about and talked about. And I think when we think about health equity, it is important that we acknowledge, even before the pandemic, where these communities have been, what are their needs, what is their current situation, and what reparations need to be done in order for us to move the health equity agenda forward, along with these issues of social justice. We know that these communities have experienced many compounded barriers in accessing health, social services, legal services, and that we somehow need to reinvent the way in which we provide care. Collaborating with non-traditional sources of service deliveries. I love hearing Dr. Kemp and his use of multiple hats, being a physician, being a pastor, being a community advocate. All of these communities need to see us in these multiple roles so that they can regain the trust that has been lost. And we also know that we're dealing with complex populations. We have talked about the relevance of intersectionality. And by that, I mean the many different identities that a person endorses. The more underrepresented identities that an individual experiences, the harder and the more compounded stressors they have. So for instance, think about a patient who might be from an ethnic, racial, underrepresented community at the same time that they represent an underrepresented community from a particular sexual or gender identity group, in addition to being from a rural area. So each of those levels keep creating a compounded stressor that makes it really, really hard for these patients to engage with our medical communities and to trust us. Next slide, please. So why, and I said it in my first slide, I think if we don't do this now, then when? I think this is a timely issue, and it's also a moral issue that pertains to social justice. When we join our health professions, we make an oath. And I think part of aiming and striving for health equity is part of that oath. Is going to require us, for many of us, to step out of our comfort zones, to be in the field, to put literally what is called our boots on the ground, and to be willing to listen to the communities, listen to our patients, and hearing some of the things that sometimes are difficult for us to do because we're busy and we're jumping from one team to another. But I do think that if we want to move in the sense of reparation and healing, we need to take a different approach, along with collaborating with a lot of the non-traditional sources of service delivery that are there. So it is, in a way, a really great opportunity to reinvent ourselves and the work that we do, and to remind ourselves that we have a wonderful opportunity to be advocates and to be the voices of these communities. Policy, I do a lot of policy work, and policy take place in many different ways, not necessarily you need to go to DC and advocate for these communities. You can do it in your everyday practice by helping and advocating for training programs, by teaching other colleagues of yours, by collaborating with community partners in how do we move forward to create a call to action to inform health equity and social justice. Next slide, please. I already mentioned the oaths that we made, but it is important also to do a self-reflection stand and to see about our cultural and contextual competence. How much do we know about these populations? And sometimes it's not easy. It's not easy to step into a community that we feel we have very limited knowledge. So it is important to self-reflect and adopt an attitude of humility and know that our patients are going to be the experts in their lives. So at some point, it's putting things in the table and says, I probably will not fully understand your experience, but I have certain tools that if you teach me about who you are, if you teach me about what your life is about, maybe we can come together and create a team effort. So it's about building that collaboration and that collectivistic approach that can help us move forward. It is important to reach out to colleagues. Something this pandemic has shown us is that with sending an email, with setting a Zoom meeting, we can collaborate with other providers, with other physicians, other psychologists across the country, and sometimes even across the world, to learn about patients from different backgrounds so that we can increase our cultural competence. So I invite you to take advantage of that approach. Next slide, please. And the other thing that I invite you to think about is, what is your attitude when you step into a room with a patient or when you're giving a talk to the community? Do you tend to take an empowering approach or an imposing approach? And what I mean by that, the difference sometimes gets very blurry, because we can be with our best of intentions and come and outline, these are some of the things that you need to do. And just by phrasing it like that, the community might perceive it as an imposing approach that, for historically marginalized communities, it reinforces the rhetoric of oppression. So instead of that, I invite you to think, what are some of the strategies? What are some of the language that you can use to empower these communities? What are some of the attitudes? And one of those is listening and be willing to be open to a different perspective and to let people know that without them, we cannot make a difference. So start to thinking about what these two terms mean to you and what is the role of those terms when you're interacting with your patients on your everyday life. Next slide. So now I'm going to move into very basic things that probably we all need to do in our practice. Sometimes we do it better than others because we're human, and sometimes we have difficult days and our communication skills go through the door when we're so busy. But it is important to have these reminders because it's going to make a big difference in our patient's life, but also in helping train those providers around us. Many of you are followed by students every day. So we have a responsibility to role model for them. What are those conversations that we want to take place? Next slide, please. And if you haven't read Carl Rogers, the father of humanistic psychology, I strongly invite you to pick up a book from him. And it basically talks about unconditional positive regard when dealing with patients. And it's about literally coming in with the best of intentions, non-judgmental attitudes, a genuineness and authenticity, humility, and to be fully present to listen, to try to put yourself in the shoes of the patients to understand their experience. Next slide, please. And one of these is our body language. Our body language is so powerful because it can transcend any language barrier. You know, sometimes it's hard, you know, I'm a non-native English speaker, and sometimes it's hard to put into words all of the things that I want to convey. But if I have someone who's connecting with me through the use of their body language, that has much more power than probably all of the words that we could say. So some of these things are, have a friendly attitude, smile. You know, I know right now we've been using masks, but this is the power of wrinkles. We can smile through our eyes. You know, people can see us smiling through even through our mask. Don't underestimate the power of a smile. Convey attention with eye contact, but yet I want to caution. Notice, learn to look at your patient's body language. If they don't feel too comfortable looking at you in the eye, you know, there's some cultural factors that play a role. For people who come from very humble backgrounds, it can be very intimidating. If the patient is not looking straight into your eye, maybe you want to consider to tailor that approach and imitate some of that behavior to help them feel at ease. Convey empathy and understanding through our tone of voice. Our tone of voice is very powerful source. I can tell you when I'm working with someone in a clinical interview is very different when I ask them about what brings them in today and if loneliness is an issue. If I say, are you feeling lonely in your lives? Probably my answer is going to be no. But if I pause, I look at them in the eyes and I said, how are you doing? Are you feeling lonely today? I'm going to get a very different response. And often it's not going to be a response, but it's going to be a tear. So pay attention to what is the language and your voice of tone to convey. Even if you, for instance, you approach your patients leaning forward a little bit in a sense of, I'm listening to you, I'm here with you. It is very, very important. Next slide, please. The other one is to be aware of the cultural norms and values. Sometimes a simple question as asking the patients, what is important to you right now? You know, if you're talking, for instance, about making a choice in vaccination, if they're being afraid to you, you can ask them, what is the most important thing for you right now? Probably many of them might say my family, my work, being healthy, all of which you can tie to your agenda, which will be hopefully to get them to vaccinate, right? But by then you're acknowledging the patient, what's important to them, and you're willing to listen, which is the most important thing. Try to minimize distractions and interruptions. You know, if you know that this is a sensitive patient, try to ask your staff to stay away from the door. Try to minimize disruptions with the cell phones, with the computer. Try not to look at the screen in the computer. That can be very disrespectful to patients. And again, I cannot emphasize the power of listening and providing space, and sometimes silence. Sometimes we tend to be very uncomfortable when silence happens, and we jump in and fill it in with words. But there is a power about giving a pause and a space for people, particularly people who come from a marginalized and oppressed backgrounds, to speak up. So you can say, I'm going to give you the room because it's important for me to listen to your voice. I want to hear what you have to say. And then pause and see what comes up. I always say, I always ask for permission, but if I see someone who's very distressed or a patient whose tears are flowing, I ask, is it okay if I can place my hand on the back of your back? Because for a lot of people from collectivistic backgrounds, that sense of touch means I'm here with you. I'm hearing you. So it's up to what comfort level you feel like, but I can tell you, for me, in one of the most difficult moments of people, it can be very, very healing. And then we cannot underestimate the doorknob moments when you're about to walk out in the room, but turn back and say, thank you for an opportunity to serve you. I look forward to continue being in touch with you, and let me know if you have any questions. Because you're leaving that door and reminding them that they're important. Many of them, people have walked out the door and they don't even acknowledge or look back. Just by you looking back, it conveys such a powerful message. Next slide, please. In terms of verbal considerations, little things that you can do, for instance, is learn some words in the patient's language. You don't need to be fluent. Just learn to say hi. How are you today? If you know that the primarily population that you're dealing with is Spanish speaking or is French or whatever it is, learn those keywords, because it's going to create an alliance, a bonding with your patients. It's so important. You know, I cannot elaborate on so many of the stories that Dr. Romero and I have from listening to participants, but one of the big factors in building trust, when I was talking about, I said, do you prefer, who are you more likely to feel like you can trust, a provider that speaks your language or someone who's probably not fluent in your language, but is trying? And they said to me, I want a provider who's trying, because what that means is they care about my culture, they care about me. And I found that to be a very powerful statement. Ask if there's a need for interpreter. We know that it's not appropriate to use family members as interpreters. So ask people and put those resources available to them, or at least let them know how they can access those resources to overcome the language barriers. And it's okay to be human. Admit when you don't know something, because it makes it more real for them. So if they ask you a hard question that you don't know, we'll talk about a legal case today. And if you don't know the answer, says, I don't know. But you know what? Let me try to find that out for you and get back to you. That will get you a long way. Ask always for permission to share. And remember, we talk about empowering versus imposing. That is huge. That's an empowering approach. When you ask a patient, for instance, may I share with you some of the facts or the knowledge that I know about vaccination? I know you're not very sure about that, but may I have your permission to share them with you? May I have your permission to give you this pamphlet to pass along? It's so empowering for these communities when you do that. And ask for their feedback. How are you doing? How are you feeling in our interaction today? Do you have any questions for me? Next slide, please. I'm trying to run so that I make it within the 20 minutes. In terms of assessment, it's always for you good to ask certain questions. Of course, we know that we live under limited time for our appointments, but try to find out what a patient's experiences have been with the healthcare system. What are some of the barriers that they face? Have they faced stereotypes? How navigating complex systems of care has been for them? Because they will feel validated when you do that. And also find what are some of the things that help them? What are some of the things that help them gain access, that help them trust to people? Just 2 or 3 questions in that regard will get you a long way. Next slide, please. I mentioned already, try to motivate and establish a collaborative discussion. Countering misinformation is very delicate, because sometimes these are beliefs that are ingrained in the community, and you don't want to make them feel inadequate or make them feel that they're less than or ignorant in some sort of way. So some of the things that you can say by that is that, may I ask you, where did you hear that information? Where do you think that comes from? And that's when you can say, well, let me share probably another perspective for you to decide what works for you. Do you see the difference with empowering versus the imposing approach? It can get you very far. Make sure that when you provide materials, they're culturally sensitive. And what I mean by that, people want to look at pictures that look like themselves. People want to listen to testimonials of people in the community that they look like them. They don't want to look at rock star people or famous people. It's key for them to trust you. Use mirroring techniques. Mirroring techniques is to see, for instance, saying, let me see if I understand correctly what you're trying to say. Sometimes I don't get things right. Make it your problem, not their problem. And then say, I understand that what you're hearing is that you have concerns about vaccination. And given all of the context that you've told me, I think it's very understandable. How can I help you? Keep an open door policy, but do not overpromise. That is important that people know that either your time is limited, and you can do that at the beginning of stepping into the room, because if not, that contributes to mistrust and deceit. Next slide, please. Next slide. Let's go through, click on all of them so we can see everything. But also, the previously I talked to you about when you're talking in one-on-one interactions, and this slide is about what do you do when you give talks. A lot of you give and interact with the communities, and essentially is for you to surround yourself with community leaders, to stand on that stage next to them and to have a dialogue with them. It's important to the community to take a step in the front stage so that they know that you have that willingness to connect. It is important to adopt what we call a reparation and instrumentation approach. The reparation approach refers to acknowledges the harm that have been done with these communities, the neglect that has happened, and all of the hardship that gets in the way of them getting sources of health information or access. So after you acknowledge that with a sense of humility, then you move to an instrumentation approach to say, but we need you. We need to work with you to make a difference to get out of this crisis. You are essential, and help convey that through every single work that you do. Appeal to the values of the community that you're going to present. Help root your purpose and the meaning of those talks in those values. Try to be interactive and spend time. I cannot emphasize. A lot of people go because we're so busy, present, and then they're out. What people want is that you stay there. You stay there for 30, 40 minutes to get to know them. Let them know who you are, beyond our credentials, beyond an MD. I told Dr. Kepter when he was saying, I'm a pastor, I'm a priest. The community needs to know that. Are you a mother? Are you a father? Where are you from? What is your background? They want to see real people behind our white coats. Next slide, please. So 3 easy takeaways because we close and discuss our cases. First one is to remind ourselves that communication extends beyond language, and that it is important. Sometimes we're afraid to stepping into black boxes because they're scary and they put us out of our comfort zone, but that it is important that we're willing to look into those boxes to make a difference. But when we do it, we need to think outside the box creatively. How can we create those bonds, those communities those links that can lead us to reparation? And our patients need us. We are in a privileged position to make a difference in our patients' lives. And I think that is one of the biggest things that we constantly need to remind ourselves. Next slide. These are some reference for you, and I guess we open it to questions or the cases now. Thank you.
Thank you so much, Dr. Garcini. As always, we love the images on your slides, and we're grateful for the wisdom that you impart to us. I found a quote. While I hope people are thinking about their questions, their comments, maybe shared experiences. There's something about this presentation that you can relate to in the context of communicating with a patient. I found a little quote from a completely different context. I'm just going to share it here. Words matter. If you want to care for something, you call it a flower. Like if you're a gardener, you want to care for something, you're going to call it a flower. If you want to kill something, You call it a weed. So just, and you went so far beyond words into body language and demeanor and tone in explaining to us the importance of these nuances in the way people respond to us. We're going to go to cases in a moment. I was just checking the chat to see if anybody put a particular question, and I don't see one right now. But we know that lots comes out in case discussions. And we have this time our community health worker and outreach coordinator, the wonderful Joaquin Muerte Abrego, who submitted not one, but 2 cases from his real world lived experience over the last couple of weeks. And so now I'm going to ask Carly if you would kindly bring up the first case. And I'm going to ask Joaquin, would you kindly unmute and present this case to us? And thank you for submitting one. And everybody on this call, you are invited to submit cases as well. We've made it as easy as you can imagine. It's a simple red cap survey. You just kind of fill in the blanks. And this is an all teach, all learn environment. So when you submit cases to the ECHO Team Hub, all of us are learning. All right, Joaquin, if you're unmuted, let me ask you to take it away and tell us your first case.
Hello, everyone. So the first case, I had the honor of being a part of a panel at an event on the West Side where they had newcomers, new immigrants who had just come into the United States. And we were talking to them about health confianza. A lot of folks were coming up to us asking us about vaccines, but a lot of people, they knew about the vaccines. They were willing to get the vaccine, but they were afraid to get the vaccine because they had heard that if they got the vaccine, it would hurt their status as they are trying to become U.S. citizens. So one of the conversations I had was somebody came up to me and said, "Do you have? Do you know?" I said, "Have you been vaccinated?" And they said, "Well, I have. I got my first and my second dose in Mexico." But I don't have boosters, and I'm afraid to get the boosters now that I'm in the United States because I don't want to get, I want to be able to get my citizenship. And I said, well, what's stopping them? And they said that there's a law that stops them. So I looked up the law, and it was called public charge. And I said, are you talking about this law? And they said, yes, that they don't want to get pushed away because of public charge. So then I said, well, I don't think that this affects you, but I said, let me ask about it, and then I'll make sure to get back to you. I said, but you should still look into talking to a doctor, or if you have a lawyer representative, you should talk to them. But they were basically like, well, I don't know. Like I would like to get the new boosters. I would like to get updated, but I just am afraid that I won't be allowed to become a U.S. citizen. So, and I'm sorry, Dr. Bergen, for whatever reason, my screen didn't update on as far as the screen share, so I couldn't see my actual PDF, but.
Okay, well, all of us are seeing it, and we do appreciate the fact that you took the time to fill it out. It was very helpful for us, and thanks for presenting that case. So the first question that you submitted for the ECHO session was, will public charge affect a person's status if they receive a COVID vaccine? And at this time, I'm going to call on one of our Hub team members who actually hasn't been introduced, but is a very key member, and that is Mia Vento. Mia, could you, for just a moment, unpack for us what the heck is public charge?
Okay,
Sure. First.
Sure. Could someone grant me screen sharing actually, because this will make it easier. Everybody seeing the correct screen or the wrong screen? Okay.
Yeah, we are seeing.
Great. Thank you.
Okay, so public charge and COVID-19. A public charge is, actually, let's go to the next one. A public charge is a test that was created in the 1800s, and it allows the US government to deny an immigrant a green card and an extension of a visa or admission into the United States because they are dependent on the government for support in some way. So that could be a ground of inadmissibility. So they are dependent and they have to decide what they test them on, and they review it. So started in the 1800s, then was evolved and became the 1999 field guidance. During the Trump administration, there was a new rule that became much stricter and barred a lot of immigrants from accessing health services that they were normally eligible for But under the new administration, the Biden administration, that law has been repealed. So big ol' X, we are back to what they call the 1999 field guidance. So that's what they use to evaluate people's immigration status. So when it comes to COVID-19, the reason why people are worried about this is like, well, technically COVID-19 vaccines are paid for by the government. That's a public service. I can't be a public charge. I can't depend on the government for anything or else my immigration status is in jeopardy. But it turns out, pandemic's a big deal and the virus doesn't care what your citizenship status is. And it's good public health to just get everybody vaccinated. So the US has gone back to the 1999 law and has made it that you will not be affected if you get vaccinated for COVID-19. And in fact, there's a mandatory medical examination for immigration purposes, and you are required to be vaccinated against COVID-19. And I will share these slides and links after this session. But I also checked that. So the previous slide was from the National Immigration Law Center. The next one is directly from the US Citizenship and Immigration Services. And they also say the same thing, like, no, we will not hold this against you.
Thank you, Mia. That was really clear, and we all appreciate having those resources and the link that you provided. And we'll all look for the slide set that you sent us out. I want to comment that this is not something that's affecting a tiny number of people. We in San Antonio are now hosting between 600 to 1,000 migrants on a daily basis. That's the number that are being processed through the Immigrant Resource Center, the Migrant Resource Center of San Antonio. And so literally thousands of people have a legitimate question here. And with all of these people coming into the United States, there's this pandemic, there's the flu, there's other pandemics that may be down the line. It's really important for all of us as healthcare providers to have a clear understanding about this. But that's the legal answer, and that's important knowledge. I'm going to go to our didactic presenter, Dr. Garcini. What are the other considerations in addressing a human being who has this concern when you're a healthcare provider and you're talking about vaccination?
Thank you very much. And thank you actually for pointing out to the fact that this is not a small proportion of our population, and we're just talking about recent immigrants, but we also have undocumented and mixed status families who have been embedded in the United States for many, many years. And they also just as afraid to go forward and get the vaccine. So it is definitely affecting a large segment of the population. I think it's very important for these communities to feel validated in their fears. We know that the sociopolitical rhetoric and actions that we've seen over the past several years are rough, and they continue to be. These communities had a lot of hope on the new administration and nothing has happened. So it kind of has reinforced the view that they're on their own. So I think starting to jump on the validation train and letting them know that the medical community, we are standing beside them, could be a huge factor. But also, I think, what can we do as physicians to go to them? We cannot wait for them to come to us. How can we bring that information to them? And I think this is the part where we can collaborate. These communities trust their faith-based leaders. Faith-based leaders are a huge voice in these communities. They trust the community grassroots organizations. I think it'll be fantastic in an ideal world if physicians can go and give talks next to them, where the people live, work, learn, and live about myths and about the vaccination and what can we do with the approaches that we discuss in the didactic to this. I think that can get us a long way.
Thank you so much. I want to call on Dr. Ken Kemp, Reverend Dr. Ken Kemp, since Dr. Garcini alluded to the important role of faith leaders. And you are, of course, someone who wears several hats as a physician as well and a faith leader. Do you have some comments to add?
Well, thank you, Dr. Bergen. I agree that faith-based leaders can make a dramatic impact upon the understanding as well as the outlook and attitude of people from marginalized communities. This is a pretty sticky situation because if you have someone who is an immigrant who has left their base of support and they are essentially strangers in an unknown land, it may be difficult for any faith leader to address that particular issue. However, if we can get some idea of what their orientation is in terms of their religious background, then someone from that community, from that religious background, might be able to help them understand what they're facing and what their rights might be, and then might trust them. So, because this is the issue, even though you're a physician or you're a public health official or whatever, and you're trying to get people to understand what is right and what is not right, they won't necessarily believe you, because in the past, the record is people have been deceived by folks in positions of authority, but they may be more inclined to take it from a faith leader from their religious background that they could trust.
Thank you. And I just want to underline something that we hope is coming through our ECHO sessions, is that obviously people have more than one identity and more than one affiliation. And Dr. Garcini, you mentioned it in your presentation as well, that somebody could be an immigrant, an asylum seeker, someone might be a person of color, someone might have a particular religious background, and someone may have a certain sexual orientation or gender identity that may be different than what is considered the normal in a particular society. And all of these factors are going to influence how they're processing information and how they're receiving information depending on who the messenger is. So thank you very much for that. I would like to go back, Carly, if you could bring the case form up, the same one we've been working on, because I believe Joaquin may have submitted a couple of other questions. I want to make sure we address them. And then how can doctors advocate for better policies for immigrants in the United States? And I would add to doctors, I would add any healthcare professional, a licensed professional in the health professions, nurse, LVN, community health workers are certified. You have a certain level of credibility. Advocacy can include direct communication to the targeted groups, such as immigrants. Advocacy can include bearing witness to what is happening. In May, Dr. Elena Jimenez Gutierrez and I were invited by the American College of Physicians to visit the Customs and Border Patrol facility in McAllen. And we visited two facilities, one for adults and one for families. And we made notes and observations about the conditions that relate to health. And we were able to submit a 9-page report about that to the American College of Physicians. So bearing witness through credible professional societies is a way that we as professionals can advocate, and that can result in additional kinds of publications and awareness raising in the media that can hopefully ultimately influence policy. I'm going to ask Carly now to please take us to the second case, and I'm going to ask Joaquin to unmute and present us his second case.
Hey y'all. Okay, so the second case was I was doing some outreach and working in barbershops, and I went into the barbershop and I was talking to the guy who was the main barber, and he was sitting on a chair with his eyes closed, and I said, "Hey man, what's going on? Are you all right?" And he was just like, "Oh man, I'm really feeling it today." I said, "Well, how are you feeling?" And he said, "Well, I'm just like, my body hurts. I'm kind of having a little bit of, I feel like I have a fever." I said, "I hope you guys don't mind, but I'm gonna step back into my car, grab my mask." And they said, "Oh man, do what you gotta do." So I went to my car, grabbed my mask. I double masked. I put a KN95, and then I put a regular mask over, just so that they didn't feel like I was, being too, I don't know, like I was just walking around with a KN95. I don't know. I was just trying to make it so that they could feel like I wasn't imposing or making people nervous, because there was other people there getting a haircut, right? And so then I walked back in and I said, "Hey, it'd be a good idea if you tested. Do you have your vaccines?" And he said, "I have my first 2 doses of vaccines, but he said, hey man, it's all BS anyway. You know, I'm tired of this, and you know, I'm tired of hearing about it. I'm tired of talking about it. And so what he said was just, man, yeah, I'm just gonna call it a day. I need a little bit of rest. But you know, he goes, but I'm not gonna get no more. I'm not gonna do no more vaccines. And I said, well, do you want to get tested? I said, I have some tests in the car. And he said, at this point, man, I really don't care. And so then I said, okay. And then he said, I'm gonna call it a day. And so then I spoke to the barber who was next to him, and he said, and she was saying, he's just really sick of everything, and we've talked about it plenty of times. He's just really exhausted about talking about COVID-19. So they said, I just want to. She goes, let me just talk to him. He'll go home and feel better, and I'll test him. I'll make sure that he tests. So she pull out a test, and then I said, okay, well, I'm gonna step away. You guys call me if you need anything. So then that was it, right? So my question was, it was an obvious case of information, COVID-19 overload and exhaustion. He is tired of hearing about it from the news, tired of hearing about it from social media, tired of hearing about it from other customers. So at this point, he didn't care, right? How do you begin to address information exhaustion about COVID-19? That's my question.
So I love that you called it information exhaustion. We've been reading in the literature about information overload, and there's even a little acronym for it, an abbreviation. IO is a big thing, but you're telling us it's not just IO, people, it's exhaustion. People are exhausted. Couple of highlights about this particular case as Carly scrolled through for us. You may have picked up that this gentleman is someone who is a barber. He's got a high school education. He was white. He comes from a poor white family that was raised in the west side of San Antonio. So there's several different affiliations that this individual has. He's also got some medical conditions that do bear on his risk for a bad outcome. He is somebody who is obese, and he also has a history of alcoholism. Those are people who would have a higher risk of a bad outcome. So I'm going to start with Dr. Kemp and go to Dr. Garcini. How do we address information exhaustion about COVID-19, and how can we apply some of the principles that we've been dwelling on today about understanding who a person is, what groups they come from and affiliate with, to inform us about effective and respectful communication?
Well, this is a difficult question, and I deal with it often from two different perspectives, from dealing with patients in my clinic, and then dealing with people who come to our church. And I recognize that sometimes people are just tired of hearing about it. And I don't know if I have the right answer here, Dr. Bergen, but I believe that you have to put it in the context of that person's lived experience. And try to be respectful of their opinion. And I'm never going to try to force someone to believe like I believe, or to even understand it in the way that I understand it. But if they respect you as a subject matter expert, which all of us are to a certain extent, then I think you have to put what we're trying to do in protecting an individual's health and the public health in the context of that particular situation. So the man who says, I'm tired, I want to go home, I'm finished with all of this, it might be reasonable to say to him, but when you go home, sir, what about the people at your home? What about your wife or your children? What about the people in the barbershop? So you got to think a little bit about them as well as about yourself. And I understand how you feel. And this is what I think is important in this situation. Maybe it makes some difference to you, and maybe it doesn't. I have patients who get really mad at me in the clinic because they're tired of hearing about COVID-19. I tell them, if they get angry, then I know I've done my duty. I don't know if I can change their minds, but I try my best to, again, put it in the context of that particular patient's or person's lived experience.
Thank you very much. Excellent follow-on from what we learned from Dr. Garcini. Would you like to add Dr. Garcini, from your perspective as a psychologist.
Yeah, beautiful. I mean, beautiful comment from Dr. Kemp. I think he's right on target, you know, and I will probably take the same approach. But I think the first thing is to tell the person, I want to respect how you feel. And I hear you, right? I validate you. I know it has been a lot. It has been 3 years. And I think also what you can use to tweak, if this person has multiple conditions, to win them on this side, and for you, it has been even harder than for everyone else. You're dealing with multiple things at one time, so that the person start hearing that they've been heard. And I think the other thing that I will take from there is to ask, what do you need right now to feel better, right? Get them to articulate how you can be a vessel to help. Maybe not only for COVID-19, maybe for something else, but that could open the avenue to then go to your agenda, which is kind of increase the willingness to get vaccinated. So how can I help you feel better? What can I do? And then, you know, at some point you have to pick your battles, but let them know that at any point, if they decide to seek help, they can come to you, that you are willing to answer any questions when it's a better time for them. I think that could also be an important avenue, your willingness to be there to provide that support.
Thank you very much for that. Carly, would you be so kind as to bring up that case report again? Because I think there might have been a couple other questions that Joaquin put in there. Joaquin, in addition to how do we address information exhaustion, he asked, what are some ways that we can help community and the community level deal with the oversharing of information and information exhaustion about COVID-19? And I guess I have to say, as a member of Health Confianza, I'm conscious of the fact that we've been out there sending a lot of information into the community. And when do we have to understand that sometimes too much can be counterproductive? I'll start with Dr. Garcini and then ask Dr. Kemp to add on to it.
Yes, I mean, this is an interesting question, right? And I think it comes from, we need to know what are their primary sources, because a lot of the time is going to be, if they're dealing with overexhaustion from multiple sources, what is your preferred way of receiving this type of information? Is it a network? Is it a social media? Is it a video? And I'm going to be honest with you, our communities don't want to read, not because they don't have that ability, because it's exhausting. They want to see a video of someone like looks like themselves with testimonial and information. And a little video, you don't need 10 minutes, that's too much. 3 minutes at the most. 3-minute faces that look like them with powerful information can get you a long way. And I think that's a way that we can kind of counterbalance that overloading of information. Very digestible, very easy, pause. And no one gets tired of message that remind you of your resilience, that remind you of how strong you are, and that give you a positive message. I think that the route of fear has exhausted all of us. So what about the route of resilience, the route of building on the strengths that have pushed us through, and a message of hope? I think we were ready for a message of hope.
I like that too, because the videos are things that people can access when they choose to. So that gets at the idea of empowerment rather than imposing. Instead of blaring in somebody's face during a TV commercial or something, you're giving them an invitation to click on a link and look at a video if they want to. Dr. Kemp, what would you like to add?
Well, I love that idea of a message of hope. I think one of the ways to combat this information overload and exhaustion is to make the message innovative, so that you're not saying the same thing all the time. I mean, they've heard it a lot. They've seen a lot of us making public presentations on television or in community meetings and so forth. They've heard it. There's hardly anybody that hasn't heard about vaccination. But maybe what we ought to do is figure out a way to make it either more appealing or more digestible, so that folks aren't intimidated by it. that the whole idea that we want to present this as hope for our community is so important. I'm going to share with you what I hope to preach about on Sunday, and I very rarely do that. But I've been thinking about talking about vaccination for tribulation, and I'm hopefully going to be able to use some of the scientific information about vaccination, but then also to talk about the tribulation of people in the scripture, particularly in this case about the children of Israel being in a land of exile, and God saying to them, I know what you're going through, and I know the plans I have for you to give you hope and a future, and to use that to talk about the previous exposure, the preparation, the hope that is associated with doing something to protect the general health and well-being of our population. And sometimes that's what people need, instead of hearing, okay, go down and get this vaccine, get a shot, and come back next 30 days, and that kind of thing. Just hearing the importance of it in a different context might make things a little more digestible.
What a wonderful way for us to end our session today on a note of hope. I want to say thank you from the bottom of my heart, starting to walk with Joaquin, who's out there in the community doing the work of going into the barbershops and interacting with the exiles who are seeking to come inside, and giving us stories that we know are timely and from our own community. Dr. Garcini, thank you so much for being a tireless educator, and you educate us with such inspiration. And Dr. Kemp, thank you for being with us and inspiring us. And I turn the talking stick over to my colleague, Dr. Raquel Romero, to wrap it up.
Thank you very much. And I'm gonna echo and be second with Dr. Bergen says. Thank you so much, Dr. Bergen. Thank you, Dr. Garcini, Dr. Kemp. Joaquin, thank you so much. And we want to hear from you. Please send us your case. And if you already send a case, please present you as a follow-up. We want to hear what happened in our community. We want to hear your experience. Please bring us the opportunity to discuss this. This is an all teach, all learn environment. We invite you to present the cases. Yes, there is a CME, CNE credits, including ethics, continuing medical education. The information is in the chat. It is the activity code for today is 100. Let me get it, 92-248. This is for today. And please remind your calendar, in 2 weeks, we have another session. It's gonna be October the 14th. And I promise it's gonna be as very informative as it has been all this time. And I would like to read this message from Dr. Garcini, for I know the plans I have for you, declare the Lord, to give you a future and hope. Dr. Kemp, thank you so much also for being that coach, Dr. Garcini, and you all have a wonderful day. See you next time.